Hello, everybody. This is Franklin Walker. I want to welcome you all to our first Power Hour of April 2021. Today's topic is going to be Black Maternal Health. We have a great panel today to get into this discussion. So let's get to it. This topic today is really very interesting and I think important to all of us. We wanted to do it this Friday in particular because next week, the 11th through the 17th, is Black Maternal Health Week. So there's going to be a lot of awareness of this topic. And so we're hoping to kick that off today. Health inequity in the U.S. has become more apparent during the pandemic, with COVID-19 disproportionately ravaging populations of color. Statistics confirm similar health outcomes for this population in other areas like maternal health. The U.S. has the worst maternal mortality rates overall compared to other developed countries, with Black mothers at least 3 times more likely to die in childbirth than white mothers. Black babies have a mortality rate almost 4 times the rate of their non-Hispanic white counterparts. So with that as an introduction, let's get into our discussion. And so I want to talk briefly with my panelists and let them give us a background on themselves briefly, and then maybe more importantly, what their organizations are all about. So Michaela, can I start with you, please, ma'am?
Sure thing, Franklin. Thank you for having me. My name is Michaela Penix, and I am the State Director of Maternal and Infant Health for March of Dimes here in North Carolina. And just a little bit about me, I have been working in public health since 2007, and I actually got my start at the Cumberland County Health Department doing maternal and child health education efforts. And I'm a proud graduate of East Carolina University's Master of Public Health program, class of 2013. Go Pirates, right? And it is my pleasure and honor to lead the work of March of Dimes here in North Carolina. And our organization focuses on lifting up interventions, evidence-based and promising practices that will help to reduce infant mortality with a special focus on preventing preterm birth, as well as lifting up health equity and maternal mortality. We are focused as the national champion for moms and babies. And we're really proud to be a part of the panel this morning.
Super, thanks, Michaela. Venus, would you go next, please, ma'am?
Good morning, and again, thanks for having me as well. My name is Venus Standard. I am a certified nurse midwife. I'm an assistant professor, clinical professor at UNC Family Medicine in Chapel Hill. I'm also the recently appointed director of DEI for education and community engagement. My education background is I went to Duke for my undergrad in my nursing, and then I went to ECU as well and got my midwifery education there. Again, currently working with UNC School of Medicine and in the Department of Family Medicine. And what we do is in family medicine, as the name says, is we are focused on the health of the entire family. That said, the entire community as well. One of the focuses I do is, or recently have brought to family medicine, is doula care, and we will get into that a little bit later. But one of the main things that I do within my scope at family medicine is that we are a residency education training program. So we have the residents that come from medical school that want to be family providers. They want to be family docs in their community. So when they are on their OB rotation, on labor and delivery at UNC in Chapel Hill, I'm there helping them, guiding them, getting them information that they may not have received in medical school directly, like caring for and focusing on people of color, and how to really be holistically caring for the woman while she is in labor and during her birth.
Super. There's going to be a wealth of things I'm going to come back and ask you about. That's great.
Thank you.
Okay, super. Tammy, can you go next, please, ma'am?
I can. Thank you. Um, I'm with the Improving Community Outcomes for Maternal and Child Health, ICO for MCH. Caitlin and I were in Cumberland County, but since have picked up additional counties, so we were not able to fund with them this year, but we still keep information readily available. Breastfeeding Klingon stickers that I've floated them, and we also are still working together with breastfeeding cities and spaces with Cumberland County. So even though we're not funding them, we're still continuing to give them information into how go forward and how just to build the village. I mean, you really have to have one person who's continuing to flourish you, but if you don't have a family, you just come down. So we're certainly there for them. I've been an international board lactation consultant for 30 years, short time. I worked originally in WIC in Cumberland County. I was the first breastfeeding peer counselor in 1992, was funded by the USDA into the WIC program. And so I did home visits to the families in Cumberland and Rayford. So we did have some outline areas that we were able to assist since they were military and they did deliver within, or if they got care delivered within the area. So probably the biggest project for me is making sure that all staff and providers are educated. Because oftentimes, you know, when you look back on, I did a paper on pediatricians and what breastfeeding information they give out. They are still using a local pediatricians here, a book that is over 100 years old. That's daunting. So we, through the program and the grant, we were able to push and provide medications in milk. I had many episodes where I worked on a labor and delivery floor. And so after the delivery, I'm ashamed to say that my coworkers, you know, we had donor milk back in our office, but they would not give it to the African-American women. And I asked, why is this happening? Well, they're going to go on WIC when they get dosed anyway. And I said, well, how do you know that that's going to happen? So I had consents made up and the patient had to sign them because the nurses made them feel very vulnerable. So now where just the NICU babies were given pumped milk or milk bank from Wait Med, now all of our babies get it. So
that's a great story. That's so powerful. Thank you for that. Okay.
of course.
Okay. Caitlin, last but not least, please, ma'am.
Thank you. I appreciate the honor to be here and to talk with you guys today. Like Franklin said, what a great name, by the way. I am Caitlin Franklin, and I am a preconception and interconception health coordinator with ICO for MCH, which is improving community outcomes for maternal and child health. We, Tammy and I, and two other of our colleagues are working in a multifaceted population level maternal and child health initiative. And in that initiative, we work to improve birth outcomes, reduce infant mortality, and improve the health status of children ages 0 to 5. We were funded in June of 2016. So although not all of us have been on the initiative since 2016, our program manager, Nina Beach, started out in 2016 with the North Carolina Division of Public Health Women's and Children Health Section, which funded 5 local health departments to implement evidence-based strategies to address each of the 3 aims I just spoke about with a collective impact framework and a health equity lens for 2 years. So like I said, we've been doing this since 2016. We have shifted our strategies and we have shifted our county. So for 4 years, we had Cumberland, Hoke, Richmond, and Montgomery County. And now we are in Scotland, Hoke, Richmond, and Montgomery County. Breastfeeding has always been a consistent strategy. We have focused on reproductive life planning and clinical efforts against secondhand smoke exposure. We have since shifted those two strategies to preconception and interconception health and positive parenting program, commonly known as Triple P, from Triple P of America. So one of the things that we're working on this year is maternal mental health. That's something we all struggle with, and what better year to do it than this year? Everything that has come into our lives in the last 365 plus days, not only as individuals, but also in our professional lives, and especially for those stay-at-home parents that already didn't get out enough, and now that they couldn't get out for safety reasons. So we have implemented the Mothers and Babies Mood Intervention Program this year. And it's just to identify parental moods that could affect baby and or children, although it is geared for ages 0 to 1. They do have a curriculum for older age children. And although it is geared towards women, they do have a curriculum for fathers and other caregivers, because we do understand that a mother and a father figure aren't always those caregivers in the traditional sense. So it's been a privilege to do this work. I've learned a lot, things that I would have never known otherwise. And Tammy and I have been colleagues for 4 years now, since 4 years. And so it's a privilege, and I'm happy to be here. Thank you.
Awesome. Well, thanks guys for that kickoff. The next few questions are going to be specifically to certain individuals about their work. So Tammy and Caitlin, I want to stay with you guys in Richmond County in your particular roles, and recognizing, Tammy, that you did work in, Rayford and Cumberland, all down in there. So not just Richmond County, but let's talk about what your jobs specifically are addressing, in your opinions, that is related to Black maternal issues, okay? Disparities, that kind of stuff. Can you speak to what you guys are doing to target that particular folk?
Right. What we noticed in several of the counties, actually, Caitlin and I have different variations of what our program is for us, but it really works well together. Like, we make it work, and that we were able to compass more people. So we reached out to folks. I'm like, how can we get the biggest bang for our buck? So we reached out to Chamber of Commerce, and I got in for their annual meeting and got a free dinner even. But what I did is, our grant also pays for pumping spaces for employees. Well, they don't have those spaces, so they've kind of slid under the guard, if you will. So I went to those businesses and gave them the education piece that they needed. That was federal law as well as state law. They had no clue. And so I worked with them with their HR folks, and we collectively created with the Cumberland County Breastfeeding Coalition, which I'm chair of, and we created a resource guide. So it's all the areas in those 5, 6 now counties, that all counties got those, no matter where their folks were delivering, they could be picked up at any time and anywhere. And the services on there mostly were free. I think there were 3 that were paid. They are paid by insurance, but at a time where you maybe didn't expect to give birth so early, your baby's in NICU, those are not your first necessities that you think of. It's, how am I going to get back to the hospital? How am I going to get my clothes washed? And so, trying to alleviate those stressors for those families. Also, I think it's really important just kind of sit and listen to hear their needs, because families, their needs are completely different. And so, we'll say, well, we'll offer a Zoom class, and we'll offer, texting information. Well, I don't have a phone. So, our counties are rural counties.
Yeah.
So they've also started, I taught 2 of the nurses in those counties just generalized information so that when they go to the homes, if I'm not there with them, I've had them call me, but they can kind of pick it up and take care of the needs. And if they don't, or if they can't, then they have me call the mom. Especially during COVID, folks that working at the health department as well as other places I know, they're doing 4 and 5 different jobs, and not one of them is the one they were placed there to do. So, I think we've done such a great job in working together as a team, me on Caitlin's calls, hers on mine. So, we really try to get the word out and encourage other folks. We have a Twitter page, we have a community page where we put information on there. April 27th, I am starting a breastfeeding Zoom class for all counties, and it's all free through grant funding. But I think the most important thing is you have to meet them where they are. We're talking about, like, again, those food deserts, and the food that they put in there is not necessarily something that they can afford. So, making sure that we are providing health equity, opportunity for all. I will tell you that we have now, in 3 years, since Caitlin and I've been here, I have done 33, 34, 35, 38 breastfeeding spaces in our school system. So we are the first state to allow the spaces to be put in place. We pay for the room and go in and present. I've presented to the MPIC team, which is superintendents, associate superintendents, and all of the principals, excuse me. I think in going, thinking larger in numbers, not smaller, you really do make an impact. The Chamber of Commerce, I picked up the superintendent of the Hope County School Board. So, and she was a lady. And so she told me, she said, I never thought about it. And I have 3 kids. So, their mindset's a little different when they're in charge because they have so many other things to do. And finding that women of color were the other large number that were having to go to their car and pump and leave it in there for their babies. So we're very proud of the work that we've done in the school systems. We're also working with breastfeeding cities and setting up peer-to-peer groups. So moms, if they want to text or Zoom each other or just call each other, that they are a support system. They can lift each other up. And we listen to our friends. We're always there to help them and to provide support for them. But they get along really well.
That's just unbelievable amount of outreach you're doing in that 6-county region right now. Caitlin, do you have anything to add to what your colleague said?
Absolutely. Just to hit on what Tammy was saying, these breastfeeding spaces in our schools, they were actually a hiring incentive for mothers that were coming. And we're talking about mothers from out of state. It wasn't even just local moms switching schools or counties. And so that was a marketing tool when they went to job fairs. And so that was a huge gain for Hope County. But like I said, we do work in currently a 4-county, multi-county region. And we are comprised of local health departments, hospital systems, various community partners in our 4-county region. And they've come together to achieve this long-term systemic change around these complex issues, such as infant mortality, birth outcomes, and child health. We specifically focus on child health 0 ages to 5, but that doesn't mean that we're still not looking at that end goal. Like Tammy was saying, each of our strategies, they're connected. So if you think of our current strategies right now, Tammy focuses on breastfeeding and that breastfeeding education. And that was a huge focus for so many years Now we've shifted into the outreach and into the community and making it more accessible to everybody. And so she focuses on that prenatal education so that when mom is postpartum, she has the tips and the tricks and the tools to make breastfeeding so successful. And from there, kind of in a merge, a little gray area, we have preconception and interconception health. You know, we're currently focusing on our pre-pregnancy services. And I know later in our conversation, we could talk more about it, but the importance of planning for your pregnancies or planning to not get pregnant. You know, we talk about these birth outcomes, and if you're getting pregnant and you're not taking your folic acid, I know we've worked with Marsha Dimes a ton of times on the importance of folic acid. You know, if you're not taking that folic acid ahead of time, there's so many things that could happen in just those first 6 weeks, which oftentimes moms don't even know that they're pregnant in those first 6 weeks. So if you're a woman of color and you don't have access to care, you don't necessarily have the financial resources to go out and buy prenatals, or you've never gotten the education to know to take prenatals, you could already be behind the A game.
Mm-hmm.
Therefore, our children are already behind the A game. And trust me, when I had my daughter 5 years ago, I had no idea. I didn't find out I was pregnant till I was 9 weeks. Thank goodness nothing happened, but I didn't take those prenatals and know the importance of them now. And so we focus on the education for not only our local health departments, but our private sector as well that are within our community, and then educating our community. Obviously, in the last year, we haven't been able to do outreach events, and that's been tough. It's been really tough. And so we try to go into that virtual sector. You know, like Tammy was saying, we do have a Facebook page. We recently created a mom group, which is so weird to say because sometimes they can be detrimental to a woman's mental health. But we created this safe space in this community for our communities. So moms could get evidence-based resources and evidence-based answers to their questions. Because we all have something to provide. And in the typical mom group, you don't get that. You get experience and emotional. You don't get the evidence-based, and you surely do not get resources. And I do not know how many times I have sent the North Carolina breastfeeding law or the North Carolina or the federal breastfeeding law to mothers that are saying, you know, I'm breastfeeding and I have to go back to work and I don't know how I'm going to do it. And it's like, wow. You know, now you have to think about, okay, am I going to feed my child, which theoretically doesn't cost anything, or am I going to feed the rest of my family, keep my four walls intact, and make sure that, you know, we're clean and bathed in our bellies and a roof over our head. And so there's moms out here that are having to make those decisions. And there's not always resources. I know that when we did our health equity impact for breastfeeding, we found out that there's 17,000 international board certified lactation consultants in the United States alone. In North Carolina, I think there was like 5 or 6. And this was about 2 years ago. And so I actually know some people that have gotten their ABLC since then. But that's not a lot. And I think there was maybe 100,000, Tammy, correct me if I'm wrong, maybe around 100,000 globally.
Yeah.
Not enough. That's not enough resources. You know, and you can't always go to WIC if you're not a participant. So where are our other resources for these things? So we've been focusing on preconception health, those pre-pregnancy education for both our providers and our patients, understanding the importance, whether or not, using that one key question, whether or not they want to have a child within the next year or so. If they do, we're going to set them up for success. Are you eating well? Are you exercising? Do you use tobacco? Do you consume alcohol? Are you using any other illicit drugs? You know, and just kind of educating without judgment, you know, because whether medicinal drugs are illegal, you know, that could be a cultural thing to others. So to be understanding and not judgmental when you're working through these things is something that we've had to focus on big time. And allowing them access to contraception methods. We have focused on IUD and implants, commonly known as LARCs, long-acting reversible contraception, for all of our 6 years. But we do have access to all contraception methods for men and women at all of our health departments. And we've encouraged that, if you don't want a baby in the next year, okay, well, maybe we should look at those long-term methods so that you're not having to focus on taking a pill at the same time every day, or having already a lack of transportation, but you need to get to the pharmacy to fill your other birth control, NuvaRing, et cetera, or having to get to the health department every 8 to 12 weeks for a depot shot. And so, we thought about those things when we were talking about access to care. Transportation is a part of that social determinants of health and a barrier to access to care. And so that's something we've discussed as well. When you asked if there was a nuisance or a nuance, we talked about the decreased access to care and the decreased utilization of care, compared to our white counterparts, and there's a need for addressing implicit bias within our providers. In public health, we focus on that a lot. And I have found that out, that in public health, especially in North Carolina, we are doing so well at providing tons of conversation around people of color and access to care and improving implicit bias. But where are we at in the private sector? My husband is an African-American male, and he also serves in the United States Army. And so therefore I get my care on Fort Bragg. And I have been on countless racial calls, webinars, trainings, and gone to an appointment. And I'll have a nurse ask me what I'm listening to. And I'll explain it to her. And she's like, wow, we don't have that here. That's a thing. And I had said that one time when I was on a training for implicit bias. And she's like, oh yeah, we don't have that here. We're good. And I was like, really? Interesting. I forgot we had perfection in this world. So there's a lot of people still in the private sector, even though that is a public entity. We still have a lot of people in the private sector that have no idea the ramifications of the maternal and child health epidemic, for lack of better words. We do all this work, and it's great that we're doing it. But the second that public health catches on to the great work that you're doing, they pull your funding immediately. So you've increased access, you've improved care, you're doing great work in your communities, your numbers have gone up, you apply to refund, and you no longer qualify because of the great work that's being done. But without that funding, that work is not going to continue, because our health departments just do not have the capacity to do that, especially now with a pandemic happening. How many resources have been shifted elsewhere? And so those are the conversations that we have in our initiative, and just kind of what we've been doing the last couple of years and what we're continuing to do. We're focusing on every step, if we're working on those pre-pregnancy services, prenatal appointments, postpartum into mental health, focusing on breastfeeding, which could be a huge issue to one's mental health. It is a very taxing thing to do sometimes, and it surely does not come as easy as marketing has made it out to be. Into the parenting. If you have a mom with a newborn, but you still have to parent a toddler, those moments are so hard. And so we have a great colleague, Joe Hutchison, and he's rocking the Triple P. And it's a great strategy. And I encourage all of you to be trained in Triple P of America in whatever capacity. They have different levels not only for yourself, for maybe one day grandchildren or your own children, but for the work that you're doing as well to better understand.
Okay, so, super. And you guys are clearly doing a ton of great work down there, but I want to switch and get back to Venus and Michaela for a second, or more than a second. Venus, I did some research and you're involved in For Moms to Be. So explain a little bit about that organization. And I know that there's a lot that you're doing with doulas. Explain to our audience what a doula is and their role in all of what you're doing there, please, ma'am.
Okay, well, For Moms to Be is a private, it's my private company, and it's an education company because I'm also trained as a Lamaze certified childbirth educator. I was trained as a doula. As a certified nurse midwife, I also teach prenatal classes. So that pre-COVID, we were in Greensboro, and that was just an education source for prenatal events on prenatal parents. So that's what that is, For Moms to Be. We also trained doulas. And yes, I am training doulas currently. What a doula is, for those who don't know, doula is a professionally educated and experienced person who's educated in childbirth and the things around it. They're trained to give advice, information, emotional support, physical support, hands-on at the delivery. So uniquely, or I should say preferably, we have the doulas and the mamas meet up in their second trimester. That would be what would be preferred, because there's so much in the African-American, Black and Brown community that there's a lack of trust between the women or the families and the medical community. So the longer that the doula can be involved in the care, involved in her pregnancy, the trust factor is built between the two of them. And again, she is taught these things that she could know, and if nothing else, resources. She is not there to give medical advice. A doula is not trained on any medical technique. I just want to make that clear. They're there really for the support angle from the different aspects that I just mentioned: information, emotional, hands-on. She also can be, and it doesn't have to be a she, it usually is, but it doesn't have to be a she. There are many male doulas. Like there are male OBs and male midwives, there are male doulas as well. But that's like a communication bridge between them and the provider. But sometimes a patient will sit there and listen to the provider talk and just, either nod or not say anything and really didn't understand. If the doula happens to be there, or she can repeat what that provider said to her, the doula should have enough knowledge or the ability to find out what was really said to translate it for her. So sometimes it's a translation thing. Sometimes it's just a communication where she'll give her some ideas to now talk to her, talk to her provider and ask these additional questions that should have been asked during that particular session, but she may not have known about that. ACOG recently, not recently, but in 2000, I believe it was 2014, put out a position paper that having a doula in the room was beneficial for preventing the primary C-section. I think that paper was called the Safe Prevention of the Primary C-section. Then they did another one that was 2017, that was approaches to limit it to intervention for labor and birth. So again, having a doula a part of the team will decrease your numbers of having interventions or having to have a safe, successful vaginal delivery. All that said, speaking of doulas, I've recently received an award, and thanks to people that support me, like the Medical Society and like the OBGYN Society and like Michaela at the March of Dimes, I was able to receive the C. Felix Harvey Award that came through UNC. And that is specifically for me to focus and train more doulas, and in particular, more Black women to be doulas. So I've assembled what I call my dream team. I've assembled a team of, I believe right now we have 11 different professional Black women. Most of them are medically trained. Most of them are nurses. Again, for a doula, you don't have to be a nurse, but the fact that I have these professional, doctoral prepared women, Black women, stand in front of and teach these Black women from our community in North Carolina is amazing. And they've assembled together to do this. And they will be teaching a variety of different things. There will be 20 doulas that will be trained. And per the requirement for certification with DONA, that's the certifying body that we go through, they will need 3 different patients to serve for their birth as a part of their qualification. So because I am a provider and I have access to pregnant women all the time, I will be, my team at Family Medicine and the Orange County Health Department, we will be supplying the women for them to serve. So that's 60 women. If they're each getting 3, they're gonna have 60 women that they're gonna be able to serve, which is just amazing. A lot of the Dream Team will be volunteering a lot of their services. I have one coming in from Tennessee. Hopefully I can get the one that's coming in from California. I have one coming in from DC. She's coming in as well. So like, this is a big deal. We've coined it like each one, reach one, teach one. So Black women are going to be training Black women to be able to support Black women. So it's going to be a phenomenal training, and it should start, the plan is for it to start mid to the end of May. Because I have so many working parts in it and so many people involved, we have expanded it to be a 5-week program as opposed to a 1-week program. Now, speaking of the program, normally a doula is one of the only, really one of the only professions within the maternity care team that can be trained, really trained successfully in a week, and be able to take on a patient or a client at the following day. Because you have to have the births for the certification. So it's not like the other way around, you have to be licensed or certified first. So they will be able to do this as soon as they finish the didactic portion. We will provide their clinical experience by getting them, the women, to be able to serve. And let's see, what else can I tell you about this? I'm so excited about this program. The fact that we're giving the Black women the opportunity and being taught by the Black women and serving the Black women, there's like a shared common lived experience that can be exchanged between the 3 levels, between the 3 groups, the instructors, the doulas, and the expected moms. There's cultural awareness that's there. We're trying to remove the lack of trust that they may feel. The diversity is what makes us. So diversity is there, because unfortunately there's not a whole lot of Black doulas in the United States or in our area. We have all these expected moms, but not enough doulas to serve as we could.
Yeah, that just sounds awesome. Let me ask you one quick follow-up question, Venus, because you had mentioned in your initial statements of your involvement with the UNC School of Medicine and your position within family medicine, and that you did some training with the OBs, right? So is there anything that you're doing to train the residents specifically to target care for women of color, Black and brown communities, versus what they've been taught before?
Well, just the fact that I'm in the room, right?
Yes, right.
Just the fact that I'm in the room gives them that sense of, and yes, as we go along, like it's a case by case basis, obviously.
Sure.
So there's things that they may not have learned in medical school, or they would not have learned in their residency training had there not been a person of color on the team. And I bring to them that perspective that they may not have. Absolutely.
Right. Okay.
Absolutely.
I didn't know if they were receiving any training or awareness on, health inequity and, access and all that sort of stuff that maybe they weren't getting trained on prior to this initiative. But
right.
anyway,
Well,
okay. Yeah, go ahead.
As a part of my new position as the director of DEI, I have lined up a host of people, not just women, of people to come to speak to our team on diversity, on medical mistrust. I have the one that I'm trying to get in from California to speak on medical mistrust, to speak on there's one that's going to be in September, and there's another one that's going to be hopefully in November, and they're talking about cultural diversity and the primary care provider. And that's what our docs are. They're primary care providers. So they can see them in any point in their lifespan, from birth to death, right? So a family provider cares for the entire family, men, women, children, and for the entire lifespan. So we need them to have that extra bit of education. Diversity is what makes us different, but inclusion is creating the cultural acceptance and diversity. And they need to be able to have that, because unless they're moving to an area that's going to just all look like them, they need to have the ability to care for, talk to, and if nothing else, or order things for people of color. So yes, we are including that within their education. Absolutely.
Yeah. Well, and it's been, I think, our experience here at the Medical Society and Power Hour, we've had this ongoing conversation about race and equity in medicine. And I must say, it's not ever an easy conversation because we've got a lot of work to do, but the fact that we're having these conversations at multiple levels and multiple venues means we're addressing it. And that's a great thing. So thank you. Michaela, you have been so patient. Thank you so much for hanging in there with us. Finally, I'm going to get to you. What I'd like to ask you is kind of the same question I'd ask the other folks, is talk a little bit about March of Dimes efforts in this area that we're discussing today, African-American, Black, brown folk, and anything that you guys are doing specifically to raise awareness or help with these issues.
Absolutely. So, we are a national organization, and so we have recognized that the maternal health crisis among Black and brown communities, it is a national one. We see similar issues in almost every state in our country. And I'm really proud that March of Dimes has been a leader in calling out the isms that contribute to our maternal health crisis. So we talk about Black Maternal Health Week coming up, and we have to be really clear about racism being an embedded and ongoing pervasive issue that's contributing to the poor maternal health outcomes that we see in North Carolina and around the country. And so March of Dimes has launched our Breaking Through Bias, Implicit Bias training. And we really focus in on the Black community and how racism and implicit bias have contributed to these poor maternal health outcomes. So for example, in the training, you'll see that we have 400 years in our country where we have experienced racism. And relatively recently in our history, we see, and I will throw up my air quotes, freedom, right, for Black families. And what I like to do is put it in perspective for folks. Myself as a Black woman, I am the daughter of survivors of Jim Crow. And that's hard for people to understand. My parents were very alive and well during Jim Crow, experienced this trauma. My grandmother experienced this trauma. And how does that in turn affect me as a person of reproductive age? When you think about generational trauma and the weathering, the content that I've heard, the stories from my parents and how they've had to pivot, and maybe how I then perceive trust with my medical community, as Venus talked about. We in North Carolina have a huge issue with eugenics. We have a strong history of eugenics here. And how does that impact our ability to trust our medical communities? And so March of Dimes recognizes that. And we recognize that we have a lot of work to do in dismantling racism and racist structures that still exist, as well as helping all of us address our own implicit bias. So in our training, we do address tools. The wonderful thing, and I would be remiss if I didn't lift this up, is that our implicit bias training comes with continuing education credits for both nurses and medical providers. So there are CMEs and CNE credits available. And then additionally, North Carolina has been a leader in the preconception health space. And Caitlin talked a lot about preconception health. And in North Carolina, we recognize that as a strong strategy to address maternal health outcomes as well as infant mortality. And so we recognize that you can't fix all of a woman's issues when she becomes pregnant. If you think about diabetes and hypertension, if a woman shows up pregnant with these issues and they're out of control, she's more likely to have a poor birth outcome. And so by addressing her prenatal health, her preconception health well before she's ever pregnant, which means that she has access to care, right? We need to make sure that everyone has access to quality care, i.e. Medicaid expansion. I'm just gonna go ahead and throw that out there. We need to make sure that folks can get into a primary care appointment. And so that's really a strategy that we know that will improve maternal health outcomes, especially when we think in the space of Black maternal health. We know that the leading cause of maternal mortality is around cardiovascular incidents. And that can not that it can be easily addressed because there's no simple solution, but one simple solution, at least contributing factor, is making sure she can have a primary care appointment before she ever gets pregnant. And that's important. We also, in the space of preconception health, understand that women, birthing people in general, we are not baby making machines. That is not all we're here for, right? These are people. And we want to make sure that everyone is treated as such. We do want to make sure that we address your reproductive life plan and what your decisions are, but also know that we care about you as an individual and your health. We want to make sure that North Carolina is full of healthy people who give birth when they choose, how they choose, and in their best possible health. And so, as I mentioned, we talked about the isms like racism, but we also talk about the other isms. They're in the medical community, and you and Venus talked about it a little bit, Franklin. There's a serious issue with paternalism. A lot of our medical providers come into the room telling you what you should do and how you should do it, instead of having a conversation with this individual about what they want for their own health and what's important to them. And so we're proponents for patient-centered care and really having a conversation with individuals. And I think that can go the distance when we're talking about Black maternal health. Treat your patients like they are people and not numbers. And I say the same thing when it comes to all of the stories that I hear. I see data every day around maternal health, birth outcomes. I also have the privilege of hearing stories every day too. These are not just numbers, these are people who have experienced loss, who have experienced near misses, families who are still struggling with their loss or even their near miss. I have a volunteer who talked about the 7 surgeries and the liter of blood she had in her belly and how her husband watched her at the brink of death for 45 days. And you think about that, she is a number, right? As a maternal mortality near miss, but this is a family. And even her struggle in considering whether or not to have a baby again. And so the last thing I'll bring up, because I know we have a lot to talk about, is around the legislation that March of Dimes is pushing to make sure that we can address maternal health in every aspect. And so again, I lifted up Medicaid expansion. It is certainly something we need in North Carolina. We are also working on a federal level, and I'm proud to say at a state level, to support the package of momnibus bills. So there's a federal momnibus package that addresses a number of issues around maternal mortality and just maternal health in general. And North Carolina has taken a stand, and there will be a package of bills that will be introduced around that as well, if not have already been introduced. Michaela is a little behind the curve on emails. But I want to make sure that March of Dimes has a strong presence in the advocacy space, as well as, Caitlin and Tammy talked a lot about breastfeeding. And we know that workplace accommodations is a necessary thing for breastfeeding moms. And we already have legislation in place, but we want to see that enforced. Understanding too in the space, bringing it right back to Black maternal health, there is a link between improved health outcomes for women who breastfeed. And so if we are not conducive to supporting that space for women to breastfeed, they're missing the opportunity to take advantage of those increased health benefits around breastfeeding. So we're here to support all of our programs, including ICO for MCH. I'm proud to stand by Venus and her doula program, and a number of the health departments and other grassroots organizations that are fighting for moms and babies, and especially for those who need the most help.
Super. And I'm glad you brought up the Momnibus bill, which means I won't have to, so we can consider that one already covered a little bit by you. But I do have one follow-up question in that the March of Dimes is a national organization. You're working in North Carolina. As you look across the landscape and compare what's going on in North Carolina versus what's going on nationally, are there anything that are specific issues related to North Carolina around Black maternal health that are not included at the national level?
Are you talking about in terms of the bill packages?
Well, I wanted you, yeah, the bill package is what I'd like to hear a little bit about, but are there any issues that March of Dimes is doing nationally, but you're seeing stuff on the ground in North Carolina that says, oh, I've got to carve this out, and we need to do something special here in North Carolina because of this certain set of circumstances?
Absolutely. So, the package of bills is going to be unique nationally versus our state level. So I won't dive too deep in there. But what I have seen in other states that I would certainly like to see in North Carolina, and I hope this will make everybody on the call super excited. I think that in North Carolina, we have a lot of work to do and have an opportunity to support doulas for everybody. We know that doulas, there's evidence, a wealth of evidence that shows that doulas are the key to improving birth outcomes, especially for the Black community. It's the secret of social support there. But it's a lot that goes into supporting doula services. Doulas should be paid for their service. So their work, they need to make a livable wage in order to do the wonderful work that they do. In order to make a livable wage, we need to make sure that their services can be billed by private insurance and Medicaid. So that's something that we'd like to see here in North Carolina. They are super important. I am proud to have been trained. I'm not practicing yet, but I'm a trained doula as well. And I certainly understand how, even though I'm super passionate about the work of doula, there's no way I could live off of doing the work of a doula. So that is something we need to see here in North Carolina. The other piece is we need to see enhanced reimbursement for group prenatal care. And so I'm staying on the train of social support. And group prenatal care, many people are familiar with centering pregnancy as the model of group prenatal care. March of Dimes has introduced a model called supportive pregnancy care. And both of them are wonderful models. There's just a little bit of a difference. We saw an opportunity to fill in the gap for practices who may not necessarily be a good candidate for centering pregnancy, because we recognize the value of group prenatal care. And the evidence shows us that there is, that we can reduce the risk of a woman having a preterm birth by up to 33% with group prenatal care, which is pretty significant. And it works well for providers, for patients, especially if we have patients who work, I lived in Eastern North Carolina for a while. Those are working in factories, or they really need a schedule of visits to take to their doctor to make sure that we are not aggravating a social driver of health around income. We want to make sure that if they don't have paid sick leave, which is another, that's another March of Dimes thing. I'm on my legislative and policy front. We need paid
or paid maternal leave.
Or paid maternal leave, right? Those are things we need in place. But group prenatal care is the magic sauce of social support. And as a military baby, Tammy, I know you can appreciate this too. Imagine our military moms and how they're by themselves in a new community, their partner is gone, and they need support and social support around what may or may not be normal for a pregnancy. And group prenatal care does that. So if we have moms in the community who just generally don't have a lot of family support or in a military situation, group prenatal care is the magic sauce. And in North Carolina, we're behind the curve. States like Georgia and South Carolina have figured it out around enhanced reimbursement for group prenatal care. So that's something I think we can definitely do in North Carolina, but we need everybody's help to do that. So I'll say, let your local legislator know that you need to see this happen in our state for moms and babies.
Super.
What's interesting is, Michaela, your your care and the care of lactation consultants, we're certified and licensed, but we don't get reimbursement for a visit unless it's a physician-driven order. We're under dietics. We're under the diet part. So they've really been working hard with Congress. You know, Catherine Sullivan at CGBI, Mary Overfield. It's changed, and we're hoping that it's going to continue to follow that arrow. But I certainly know what you mean. It's frustrating.
Well, you guys have answered a couple of my questions about what we could do to help you, both as citizens and at the North Carolina Medical Society. So I'm going to move on. We're almost at the top of the hour. I want to go back briefly to everybody and ask you the same question. We started Power Hour when COVID started. So tell me, just give me two things, because we don't have much time. Two things, starting with Venus, that COVID has affected your work in this area, how it's affected your area.
Well, I guess the first thing is people were afraid to come. They were afraid to come to their appointments. So it kind of propelled us into doing phone visits, virtual care. We were planning that, but when COVID hit, that just propelled us to do it a lot faster. And slowly but surely, people are now coming back back into the office. The other thing that I think affected very unfortunately is mental health. Because women are now if they're being socially distanced and they're staying away from people that don't live with them, that's what Mandy Cohen says, people that don't live with you, you're supposed to keep your distance. So they're home, and especially first-time moms, they're home by themselves. Their partner may or may not be in the home, or may be working, or may be military, like some of the ladies have spoken. So they're home by themselves with this brand new baby. And they have this, stressful new life that they were not prepared to do alone. They were prepared to have their mom and their auntie and their best friends help them with this, but because of COVID, that has distanced us to be more Zoom oriented. And Zoom is good and it keeps us up to date, but it does not replace a hug. Sometimes you just need a hug, you need somebody just to take the baby for a few minutes while you go take a shower, while you just have some rest, while you walk outside and not hear a screaming baby. So it has increased more maternal mental health wellness than I think the physical part.
Yeah. Well, I think we've all been subjected to COVID and its effects, and certainly mental health has been one of those big things. Caitlin, I'm going to keep you to 30 seconds in this answer because we're just about out of time. So tell me, from a Richmond County perspective, maybe a couple of things that has affected your work down there due to COVID.
So I want to say outreach and access to care. Access to care in our health departments is slim because it's by appointment only, and therefore if you had 50 appointments for the week, we maybe are seeing 10. And do not quote me on those numbers because they are totally false. But our clinics, all of them, if you have a medical license of any sort, you have been pushed somewhere else. If you're a processing assistant, well, you're now a COVID processing assistant. And so that's been unfortunate. And it's just now that we're seeing more access to care being opened up, now that there's a little bit more movement, here we are a year later. Unfortunately, outreach is not something that we've seen movement on. We have done 2 drive-by outreach events where you can hand your items in a bag or a backpack, etc., through a car window. But other than that, there is no interpersonal connection. There's no conversation to be had, and they're just getting education on pamphlets, and we've all thrown a pamphlet away before. So, those have been our disparities through this whole thing within our communities.
Super. Thank you. Well, listen, we're at the top of the hour. I want to thank all of my guests today for a very robust, informative discussion on Black maternal health and what you guys are doing actively in North Carolina to address this. And one thing stands out, that each one of you is very, very passionate about your work, which is just awesome. So I want to thank you guys. I want to thank the audience for listening, and I want to welcome you the next time in 2 weeks to our next Power Hour. So we'll see you then. Thanks, everybody.